COVID, but this is the start of it. The Gordon Lecture was named after Dr. Phil Gordon, who was the first fully trained colorectal surgeon at McGill and in Canada. He was the founding president of the Canadian Society of Colon and Rectal Surgeons and was the only non-American to serve as president of the American Society of Colon and Rectal Surgeons. He authored many textbooks, which are references for colon and rectal surgery, authored many peer-review articles, and garnered an international reputation for colorectal surgery and himself around the world. We've established this lecture in his honor and to the fact that his devotion and inspiration inspired many of us who are presently in colorectal surgery, not only here, but across Canada and the US, to pursue careers in colorectal surgery. As our featured presenter, we are honored to have Dr. Don Buie, who was originally scheduled to come to us 3 years ago, but as I said, was preempted by COVID. And just to let you know about Dr. Buie, he is currently chief of surgery at Foothills Hospital in Calgary, and he's director of the Colon and Rectal Surgery program in Calgary. He did his general surgery residency at the University of Alberta, as well as a master's in experimental surgery, and did his fellowship in colorectal surgery at my old alma mater, University of Minnesota. He then returned to Calgary and set up a solely colorectal practice at Foothills Hospital. He served on the Royal College as an examination chair for general surgery and as a member of the examination board for colon and rectal surgery. He also served as a board member of the American Board of Colon and Rectal Surgery, was its president, and is still a senior examiner. And yesterday, when he was giving mock orals to the residents, we saw his expertise in not only giving the questions, but being kind, gentle, and teaching all at the same time. He also served as co-editor of Diseases of Colon and Rectum, and he was chair of the Practice Guidelines Committee for the American Society of Colon and Rectal Surgeons. He's been a co-PI for setting up standardization of rectal cancer care in Alberta. And we saw some of the expertise yesterday when he gave us a lecture on the history of rectal cancer, which was instructive to our residents and fellows. Today, he's going to talk to us about when we know what we know, bringing evidence into surgical practice. I would like you to welcome Dr. Buie, and let's hear what he has to say.
I'm going to unmute myself.
I just unmuted myself too. Good. Caroline, thank you very much for the kind introduction this morning, and to all the staff at McGill. I'm very appreciative of your inviting me to come today and speak as the Phil Gordon Lecturer. This is really an honor for me. Phil was really certainly a giant in colorectal surgery, both in Canada, internationally, and throughout the world. And it's really something to be held in or brought forward for this, just with him in mind. One of the first introductions to Phil, as for many of us, was with his textbook. And as I left my general surgery residency, this text was given to me by my mentors because they knew I was going into colorectal surgery. And I certainly think a lot of the book, it really was something that was different at the time, and actually sort of, I think, was trailblazing in the way it presented information. And throughout my career, Dr. Gordon, when I finally did meet him, he was very helpful and very much sort of in the background of my career. And I think there was some times when I'm pretty sure that he was influencing what was happening. I have no conflicts of interest to declare. First, I'm going to start with an apology. The worst way to start a presentation. Apologies to the epistemologists in the crowd. I'm neither a philosopher nor an epistemologist. My title today is a famous philosophical question: how do we know what we know? And I can't talk about that. So what I am going to talk about today is, when do we know what we know? When is it that we accept the evidence and put it into practice?
Dr. Buie, the chief at Calgary and the Colorectal Surgery.
When I finished my residency in 1990, surgical dogma consisted of the following: drainage of the gallbladder bed and all the open cholecystectomies, NG tubes in all patients with bowel resections, and in hospital bowel preparation for all colon resections. And that corresponded to mechanical, oral, IV, and on induction. What happened to all that? Well, they've all gone away except the full bowel prep, as you know, and we've almost come full circle with respect to that. And as Lord Bacon, the father of inductive methodology for scientific inquiry, said many years ago, much that was solid has sunk into the river of time, and much that was light has floated. The outline of today's talk, we'll talk about accessing quality evidence, then about evidence summaries, specifically systematic reviews and CPGs, and some new methodologies which are coming into the fore, some barriers to putting evidence into practice, then just a little bit about implementation science, and finally just about implementation new technology, because after all, we are surgeons. You'll note that the fundamental principles of evidence-based medicine, really, there's sort of three. Optimal clinical decision-making requires awareness of best clinical evidence. EBM should provide guidance as to whether evidence is trustworthy, including an estimate of effect. And finally, evidence is not necessary, is necessary but not sufficient for clinical reason and decision-making. And as you can see, there's evidence in every one of those statements. And that's the underlying issue today, of course, is how do we access this evidence? Then traditionally, when I was coming through as a resident, there was a lot of limitations. There was certainly less research, less publications. There was a time lag, and I remember going to the library for the Index Medicus, which came quarterly to update all the current evidence, and it really was very behind relative to today's standards. The summaries were primarily narrative when you did look at a summary, and of course, many people got their information from textbooks and of course, end of year books, which were really points of view. Nowadays, it's really better than ever, it seems. There's the digital age, there's instant access, you've got preprint digital publications, and there's a robust peer review process. Important studies are generally released quickly, especially, for example, with COVID, where studies were coming out almost by the hour. There's robust methodology for summaries.
See if I can pick it up.
There are some limitations, however. There's a massive volume of data available, and with that, of course, comes a lot of chaff. And you're trying to sort out between the wheat and the chaff, and often you need some expertise to collate and translate this conflicting data, because it isn't always in the same direction. And of course, the last thing is time. We just don't have enough time to do that in our day. This graph actually just shows you citations added to Medline by fiscal year, and you can see, I don't quite understand it, but it's going up yearly, but there's a huge jump last year. So either we were holding a lot of things back with COVID, and then we finally got on our horse to get it in, or there was just a renewed interest as we were all off work and we were actually getting our work done. That was something was on the back burner, but we had a huge amount of influx of citations. Overall citations now in PubMed are 38 million articles, as you can see there, and that's about almost 1.3 million, 1.35 million articles. And if you calculate that out, it's about 3,500 articles in PubMed every day.
Dr. Mulder.
It's not finding the evidence, obviously it's finding quality evidence within the evidence and trying to summarize it. You'd like to have it in summary form for your time. And I like this cartoon. It comes from Lancet in December of this year. You can see there's the 3 pedestals: yesterday, today, and tomorrow. And evidence is trying to run through that. And I like the aspect where it's handing off some data. And I think that's the evidence that's going to survive from our present time. And we really don't know quite what that is. And it's really not that much, is it? It's actually quite a small amount. Without quality evidence, there's uncertainty, and that's both in patient variations in care, and then there's under and overutilization of services within the system. So we have a lot of evidence. We would like it in summary form. And our methodologies nowadays, there's really 2 primary methods: that's systematic review and meta-analysis. And of course, the difference between them is meta-analysis gives you an estimate of effect. And they're not quite synonymous, as you can see. Unfortunately, the data may not allow for meta-analysis. And so you have to sometimes be content with a systematic review.
Okay, I'm trying to.
What are systematic reviews? Well, single studies are liable to be unrepresentative and less misleading. They collect and appraise a number of primary studies, and this takes time, of course. When a systematic review is done well, it can provide all the relevant evidence. When combined with meta-analysis, it provides the best estimate of effect and an assessment of confidence.
Thank you.
Includes a greater range of patients, enhancing confidence.
Sorry, could everybody turn off their mic, please?
Thank you. It includes a greater range of patients, which enhances confidence when applying the results. Unfortunately, systematic reviews do have limitations, however, and it's often finding an appropriate systematic review may not be possible due to the fact it may not exist. The primary data may be so poor that the actual review is not of any value. The methodology may be poor, it may be too specific or not specific enough, or it may not have an estimate of effect. Another way to get summaries, of course, is clinical practice guidelines. And I picked one here from the CSCRS, which is done by a number of authors. In fact, 3 authors from McGill, so Dr. Lee, Dr. Boutros, and Dr. Feldman. And I like this because it's one of the aspects is it's using 2 societies who have come together to actually come with a common purpose and then a common CPG, which is really what we need to also concentrate on, because there's a lot of CPGs out there and we really could avoid duplicating work. CPGs themselves are informed by systematic reviews and meta-analysis, especially randomized controlled trials, and it can assess benefit, harms, and alternatives, and it really has statements of best practice, which is really how to perform and what to do with patients. It covers multiple important questions of management, and it's done in a reproducible format, so there actually is science behind it. Some of that science actually comes from Canada, and that's the grade system, where it's called the grade of recommendations and level of evidence, where we take the statements, look at all the evidence, and we rank it either high, moderate, or low, or very low quality, and then have a statement of effects. So it's either a strong recommendation or a weak recommendation, and that depends on whether the risks and benefits, say if the risks and benefits are equal, it's weak, but if the benefits far outweigh the risk, then of course it's a strong recommendation. And those determining strength of recommendation really is under 4 sort of categories: the overall confidence in the effect estimate, the balance between the benefit and harm, if there's any uncertainty and variability in patients' values and preferences, and finally, if there's resource considerations that have to be included. CPGs certainly have their challenges, and I've already mentioned the fact that the quality of primary evidence and sort of garbage in, garbage out is very important. And that's no more true today, because there's a lot of also ran evidence. That volume of primary data becomes a problem, because how do you know that you've actually gone through the entire data catalog to find all the good evidence? And that other aspect of staying clinically relevant, with regular review and updates, incorporating new evidence. And when you've got a seismic shift versus an incremental shift, you really need a full update. I spoke about multiple societies providing similar topics, and we need to combine them. And really, it's about 3 to 4 years to produce a well-done CPG.
Is not there? I don't see her name yet.
the interesting thing is that COVID has had an effect on data, and call it the COVID effect here. And it's come up with a number of solutions. The amount of data that was coming out, as you remember back in 2020 with respect to COVID, was enormous. There was around about 200 new papers per day being logged into PubMed, all with varying, varying amounts of relevance and of methodologic quality. So people had to come up with enhanced search strategies and came up with a concept called dynamic summaries, which I'll talk about now. One of the things that came forward is something called Trialstreamer, which is a living automatically updated database of clinical trial reports. And it's powered by artificial intelligence. It's an evidence surveillance system which combines machine rule learning and rule-based methods. And it's automated to find and categorize all new randomized controlled trials. There's structured information automatically extracted and put into the database daily. And as of the publication, which was as you can see, in 2020 later, there was 670,000 published RCTs entered into the database, of which 22,000 were published in the first 5 months of 2020. That's 142 a day of randomized controlled trials. So that tells you what we're up against here. Presently, this system is functional for COVID-19. So if you go online, you can find this database and you can look up any trial. And the way you look it up is by looking up population. You look up the intervention you're interested in, and you can come up with all the trials that are relevant to your question. So it's very useful, very quick, and it is updated daily. How well does it work? Well, they looked in this study in 2020 at manually indexing all these trials versus the automation, and you can see that with manual, that's the yellow line, you're just not quick enough to pick these things up. You have to find them, you actually look again, you use a different mesh term, and whereas the computer picks it up instantly. The second thing that's come up is something called crowdsourcing, and we're all familiar with that through social media. Well, we can harness that with randomized controlled trial and data searching. And there's something called the Cochrane crowd. And you'd sort of think to yourself, well, who's really going to do that? Well, as a matter of fact, there's at this point, there was 19,000 contributors from 163 countries, people who were willing to go through data on specific questions. And they have processed over 1 million records, identifying 178,000 randomized controlled trials. You can see when they looked at the sensitivity and specificity and accuracy compared to manually looking at these things, it was very, very good. And the proportion of records that required expert resolution, meaning they had all these members of the crowd sourcing it, it was up to between 16 and 20%, depending on the tasks that were given to the crowd. And if you think about that, that's a huge decrease in work volume. So that's 80% of the work at least is gone. And that, again, is a huge help in trying to sort out what records are important and what data we need to assimilate. So the results are accurate. You can scale it because, of course, you can just get more people. And I'm certain that it has an important role to play in study identification in the future. You can see on this slide, the graph on the right, that's the number of people who are willing to become part of Cochrane crowd, and it's just increasing at a steady rate. On the bottom left is a slide, and the only thing you need to recognize is that the black at the bottom actually is the crowdsourcing, and then what they did in this study was actually add in machine learning, and that's the purple. And you can see there's a huge increase in the number of studies that are processed in using both methods at the same time. The last thing that's come up was fascinating. It's called living evidence, and it's important where topics have rapidly research is rapidly emerging and the current evidence is uncertain. And what happens here is that researchers continuously monitor bibliographic databases to identify new research with the aid of technology such as natural language processing, machine learning. They include crowdsourcing here, and fair data sharing, which is just putting data in a reusable digital format. It allows rapid incorporation of studies and frequent cycles following established methods of high quality synthesis and guidelines. As an example, the Australian Stroke Foundation reduced their time between guidelines from about 7 years to under 3 months. That picture there, you can see all of those circles represent the data timelines where something was published in the literature, and then it goes in that arc up to the green dot, which is the date of publication for the standards or the guideline. And you can see then after that time, they're actually looking into this very rapid turnover, and each of the orange dots is a new publication of a guideline. So in fact, the guidelines now are coming out and being revised every 2 to 3 months with new data. This was put to great use with COVID-19, and I wasn't aware of this until just this past last few months, where they were using all of these criteria to update and incorporate data into COVID-19 guidelines. And you can see that was coming out almost weekly by the end of this time period. So they were actually having new guidelines come out weekly. This allowed strong recommendations against hydroxychloroquine. You remember that the Canadian, we were very much against hydroxychloroquine almost from the start. And it's because of this rapid data synthesis. And in fact, I didn't realize this as well, but a project called COVID End was a collaboration where they used living evidence to keep the Canada's Public Health Agency updated on COVID-19 vaccine effectiveness as all of the new variants of concern emerged. And we had extremely good data, and the actual public health was extremely consistent in their recommendations on vaccines. And that's because of this rapid assimilation of new data and rapid creation of new guidelines. So I think this is the future. And as a matter of fact, the NICE, National Institute of Health and Care Excellence in the UK, has promoted living guidelines as a pillar of its new improvement strategies over the next 5 years. So they've already incorporated this in. And WHO is promoting living guidelines as standard methodology, and it's presently used in their armamentarium for COVID-19, maternal and perinatal care, and contraception. And in the general population between 2020 and the end of 2021, 100 living systematic reviews have been published. So this is here to stay, and it's already being used. What is required for it to keep going? Well, one of the things, of course, is reduce unit costs, both time and effort, and we'll need some technology to help that. We need to try to prevent research waste, focus on funding on a smaller set of high quality reviews, and encourage collaboratives, as I've mentioned before. The publishers can do this, and they really need to help us, of course, optimizing early publication. And the last thing, of course, is try to facilitate implementation. And this is obviously, it doesn't matter if you get the guidelines out there, what are people going to use them and take them to heart? And that's the second part of my talk, really, is, as stated there, it doesn't matter how good the guidelines are if no one uses them. And so we really need to look at implementation, sort of like Fernandez there. She's got a game plan and she's got to get out there and actually do it. And that obviously sometimes is harder to accomplish, obviously. I like this quote from Dwight D. Eisenhower, and I used it yesterday with the residents. Motivation is the art of getting people to do what you want them to do because they want to do it. So putting evidence into practice, sometimes we adopt too slowly, sometimes we adopt too quickly, and sometimes, unfortunately, not at all. And this is the source of my topic, or the topic of it. When do we know that we know? Historically, how was evidence disseminated? How long did it take? This is a paper from 1992 outlining a cumulative look at the RCT evidence for thrombolytic therapy in the treatment of acute myocardial infarction between 1960 and 1990. You can see the year along the left-hand side, followed by the number of cumulative randomized controlled trials, the cumulative patient studies totals in these studies, and then the odds ratio on the right in the next column. And on the right-hand side, there's the recommendations in the literature over that time period, ranging from not recommended to routine. And I would like to make 3 points. The first, by 1972, enough evidence had accumulated to determine that the thrombolytic therapy was an effective treatment with a p-value of 0.01, as you can see there. Second, so that's as we're talking about there. Second, despite this, RCTs were continued for another 20 years until almost 48,000 patients had been enrolled in randomized controlled trials. The third point then is if you look on the right, through most of this time, most of the textbooks and reviews did not even recommend thrombolytic treatment as a standard of care. And it was not until 1980, after 6,000 patients, that it became a recommendation in a specific situation. In 1989, there was still one reference that advised against its use, despite the fact there was 48,000 patients that had been randomized. So sometimes we need to be hit over the head with a sledgehammer, I guess. It begs the question as to when are we comfortable with change? Certainly there, as an individual, how we think influences our adoption. Daniel Kahneman, of course, popularized fast and slow thinking, heuristics, and cognitive biases, and he talked about two systems of cognition: the rapid system, which is intuitive, associative, effortless, unconscious, and you can't turn it off, and then system two, which is slow, deliberate, logical, deductive, requires effort, will, and can fatigue. And if you think about it, guidelines are produced with system two thinking, and of course, practice to a large degree consists of system one thinking. And so there's a little bit of a disconnect there. I think surgical dogma also gets in the way, and I think Rudyard Kipling sort of summarized this well. We think so because all other people think so, or so because we think we in fact think so, or because we were told to think so and we think we must think so. And really that's confusing, yes. If you read it slowly, it makes sense. And in fact, that is dogma. That is exactly what dogma is. It sort of harks into something I call emotional-based medicine, another form of EBM, and the barriers to adoption. And of course, when we have something new, we're a little anxious, we're uncertain, there's some thoughts of loss, and if there's minimal perceived improvement, we're not happy about it. We also, as surgeons especially, have security in familiar patterns. We do our anastomosis the same way, because if it leaks, we know that we've done it 1,000 times the same way, and so it's not the way we do it, right? And of course, that's very, very secure to our psyche, and of course, something that we rely on a lot. Loss of autonomy, of course, is another part of this, where somebody's looking over my shoulder and then measuring my performance, which of course nobody really likes. The second thing, of course, is the environment that we work in and the organizations that we work in, and of course the culture, which is either accepting of change, forward thinking, either a fixed mindset or a growth mindset. And of course there's other practical barriers, which are economic, systematic, and resources, which come into play as far as whether we're going to accept something. Now, there's a lot of, within that context, there's the social implications of a group, and something called diffusion of innovation, which is the social processes of how we actually, or how innovation gets through a societal change. And there's really four components. This is a process. It was originally described by Everett Rogers, published in 1960, and it was based on the uptake of new corn varietals in Iowa, and how they could get farmers to take it on. And of course, they are super resistant because they've always planted this variety of corn. But you can actually, as humans in groups, there's actually methodology behind all of this. And you can see it's innovation, communication channels, time, and a social system. And I'm just going to go through those four elements. The innovation, the characteristics, there has to be some sort of relative advantage, which is very important for the innovation. It must give you some advantage. It must be compatible in some way with what you're already doing. It should be trialable. In fact, you could then try to see it, do it yourself. You need to be able to observe it. And it shouldn't be too complex. And I think this is one of the issues with lap chole, where we sort of underestimated the fact that it was a little more complex than an open chole. In fact, we had to think about it differently. We didn't recognize that right away. Communication channels are the second element, how a message gets from one individual to another. And this is a huge change right now. Of course, social media has changed this tremendously, that creation of knowledge, how we get it around. And of course, that's the interpersonal channels that come with that are effective in forming and changing attitudes. And there was a large experiment by Pfizer in 1966, and they found this theories from Everett Rogers, and they tried to apply it to a new drug, hypertensive drug that they wanted to introduce into the populations. And in fact, what they found was that if you used a detailed person and if you also paid one of us to become a speaker, it worked, and we bought more of the drug. And so that, in fact, that study is the reason why the drug companies and the mechanical device companies come at us the way they do, because it works. Most individuals evaluate an innovation not on the basis of scientific research by experts, but through the subjective evaluation of near peers who have adopted an innovation. This was Everett Rogers in 1960. He actually got it. The third element is time. And that decision process, you start with the knowledge of it, you persuade yourself you're going to try it, you make a decision to try it, you do it, and then you either get confirmation or not. So that takes a bit of time to go through that process. And that, of course, there's two aspects. You all know that graph on the left, that normal curve, and you can see, of course, the innovators, early adopters, and there's sort of a chasm that happens between early adopters and the early majority, where that's the tipping point. As soon as you get into the early majority, it's probably going to take off, and whatever the innovation is, it's probably going to take off. The rate of adoption of a social group is a different matter. And so that curve on the right can be more or less steep depending how conservative people are and what the numbers are, the spread between the group. The last item is the social system and the related units. And of course, the structure of the social system can be helpful or obstructive to new innovation. Norms, there's opinion leadership, which is important, and consequences. The types of innovations and decisions that are made, there's sort of three types. Optional decisions, of course, are just the individual saying, I'm just going to do this. And then collective, we all decide we're going to do it together. And of course, authority is obvious. Somebody's going to tell you what to do. So that all depends on the type of social system you're in. The interesting thing, the change is still at the individual level. So socially, we get influence, but we still have to make an individual change. And it's usually, unfortunately, not on evidence, but on emotion. Somebody has to emotionally engage us in some way on the aspect. So from Roger's point of view, he actually came up with a number of social strategies to influence adoption of an innovation at the individual level. And you can see the four of them there: to stress the beneficial characteristics of an innovation and create a desire. And this is how they sell you cars, they sell you anything. And it's very obvious this works. Provide a positive reaction and benefits for early adopters. Communicate through interpersonal channels and provide information. And unfortunately, I say this and I don't mean it in a negative way, but certainly the original detail people were young, attractive women, because most of the audience was older males. And there's no doubt that that was what they were after. They knew that number two, that was the best way to get that across to people and across to the audience that they had at that time. And that is still true today. They bring people in and talk to us, and they are very well versed. And don't kid yourself, they know exactly what they're doing. Provide opinion leadership. So a strategy adopted by a highly respected individual. And when you go to a meeting and you go to the area where all the companies have their products on display, you'll see videos with or a talk given by one of us who is a highly respected individual within the society. And I think the last thing is trying to get people away from optional innovation, because that's really small potatoes, just one at a time. They really want collective innovation, where we decide, for example, as the American Society or the Canadian Society of Colorectal Surgery, we say this is what we're going to do. And that's when they know they've got us. And pharma, of course, and medical instrument companies have embraced this. And I think, thinking about it, we should use some of these techniques when we're trying to get people to adopt clinical practice guidelines. I think it will work. We know that it works. Sometimes it feels like this, but not always. And there actually is a science behind all of this that's growing, and it's really in its infancy, the implementation science on how to improve uptake. It requires knowledge translation, and in fact, that is a Canadian word and a Canadian invention. It came in 2001 from CIHR, and this is an abbreviated version, actually. The effect and timely incorporation of evidence-based information into the practices of health professionals in such a way as to affect optimal healthcare outcomes and maximize the potential of the health system. It's a big wordage, but if you read it, it actually makes sense. And that's what we're trying to really do, is get people to do the right thing with the best evidence out there. If you're looking at guidelines, what makes them adopted more readily, they're obvious, very obvious. Adaptability, usability, you can read through those on the left, and it's obvious what decreases adoption. The complexity can be overcome when the advantages are significant. So if something really does work, we'll grab onto it. There is a number of strategies that have been tried to change practitioner behavior outside of just having a guideline. So in other words, the guidelines out there, how do we get people to actually do it? And some of these you know already. And this is actually, there's a whole section of Cochrane devoted to this research. So CME meetings, printed digital materials, podcasts are new and they are really not totally explored yet, but I think they're coming. And of course, social media is a huge thing right at the present time. The social influences of preceptorships, educational outreach, opinion leaders we've talked about, prompts, reminders, and feedbacks, so computer decision systems. Choice architecture is interesting, where it's basically what you do is you have a series of computer prompts or system guidelines where you actually guide the user into the decision that you want. And it's quite an interesting field in and of itself. It comes from economics. Audit and feedback are controversial because often what people do is they know that this is what they're being measured on. They often job the system to get, so a good example of that is in colonoscopy, where we're told that you have to be at least 6 to 7 minutes of withdrawal time. Well, some people will go in and they'll just fool around in the cecum for a couple of minutes and then come out. Well, just so they get their time right. And you'll get the number you want, but of course it's not the result that you're looking for. Practice guidelines, CPGs I've talked about, and of course ERAS is huge in Montreal here and elsewhere now. You guys were really the pioneers in Canada for it. And of course that's clinical care pathways, and that helps get behavior. Incentives, rewards, we try not to talk about that because I think it's very controversial. How effective are these strategies? Here's just some data that they have within Cochrane on it. Just a summary, all the strategies are effective under some circumstances. The improvements in behavior are modest. You can see the percentage behavior in all of those. And the opinion leader, interesting enough, is the strongest, which is somewhat surprising, but maybe not so. None are effective under all circumstances. So we really need a lot more research in this to try to find out how best to get people to do what we want them to do. When you're choosing a strategy, you need to look at why what you're trying to change. Is it technical, a change in practice, or acquiring new knowledge? And look at the local situation. And you may need to use sequential interventions to get people on board. The last section here is about surgical innovation and new procedures. And one of the things, of course, the scariest part is when we're too quick to adopt a new procedure. And I think we have a couple of examples of that. You can see here, 85 was the first lap chole. We all know this literature. I'm just in review for you. 87 and 89, Morin and Dubois did the same and published on it. And they published before Mew, so he was actually late being given credit for the first lap chole. He'd done about 90 of them by the time the other two guys did their lap choles. And by 91, of course, it was available to the public really throughout Canada and the USA. And I was going down to Minnesota for my fellowship in 91, and I'd never done a lap chole. I went down to Minnesota and I started doing lap colectomies since I came back in 93, and I had to get preceptored and proctored to do lap choles when I started practice. So it was a fascinating time. The bad news, of course, is that their initial state audit on data between 88 and 92 and bile duct injuries tripled in North Carolina during that time. And they've estimated it was about 2% of all the choles at that time had a bile duct injury in North Carolina, which is really scary, something that we've never, ever seen before. At the present time, just so you know, it's down to about 0.2%, ranging from 0.1 to 0.8 in the literature. We learned about it a little bit slowly, and we talked yesterday, and Lawrence Lee gave us a very good review of TATME, and I was really pleased to see how careful your own group is with the introduction of this and how you're looking at your own data. But early on, it was associated with a high number of urethral injuries and a complication that was virtually unknown with either an open or laparoscopic approach. And it got so bad that a moratorium was placed on this, both in Norway because of increased morbidity and in the Netherlands because of an unusual local recurrence pattern that we'd never, ever seen in any other form of APR. So perhaps they're learning, perhaps not. The two procedures, the things they have in common, I think these are the danger signs. Both promise significant benefits to patient recovery, something we really want for our patients. Both came highly touted and were rapidly adopted. They're adopted into practice frequently after minimal amount of training, sometimes just a weekend course, and often without proctorship or institutional oversight. And there was a lot of pressure from industry, both direct and indirect, to take this on. And I think all of those things really need to be careful with. When you poll surgeons about introducing new technology into their practice, and this is a survey of 150 faculty, 98% of them have learned a new procedure post-residency. And how did they acquire the skills? Is most commonly by scrubbing in for cases performed by another surgeon or self-directed study. But interesting enough, most surgeons felt that performing cases supervised by a proctor or mentor or a mini fellowship would be the most effective strategy. And they stated that they just didn't have the time to do that, but that's probably what they should be doing. Another study by Rietzman Marina, the authors who had published on innovative procedures frequently felt their work was research, but they didn't think that they needed IRB approval, which is kind of a dichotomy, obviously. The minority mentioned that the innovative nature of the procedure was mentioned to the patient in their informed consent, which of course I think also is kind of skirting the ethics lines. I think one of the other parts from our medical colleagues, which irks them, of course, is the medications and medical devices are typically heavily monitored and regulated, but new techniques and procedures are mostly unregulated. And I think to ensure patient safety, we really got to start watching this more carefully. And I think as a surgeon that have to do this. There's a couple of groups that have got some position statements and methodologies on this. Society of University Surgeons, we don't have to read through this, but they have a position statement on responsible application of surgical innovation. There's the ideal collaboration, which has a five-stage process for introducing new things. So the proof of concept, developmental stage, exploration stage, assessment stage, and then finally the long-term study stage. And I think this is something which we can really look towards and perhaps put into widespread use with new technologies to be safely introducing it to our patients. What can we take from this? Well, it's critically important that surgeons take responsibility for careful evaluation of new procedures and innovations. After all, we're the ones that really know the dangers. We also know the benefits, and we also know what it's going to take to move in that direction. We, I think, certainly need oversight. Like anybody else, we're not any better than anybody else. We need Surgical Innovation Committee, and we've started that in Alberta. In fact, we have a provincial Surgical Innovation Committee for this. And all new innovations have to go through that committee and have to be evaluated both economically and practically within the practice. Research Ethics Board would also suffice, or Institutional Review Board, and patient safety, of course, is paramount. And we need to make sure that these informed consents are inclusive. You must be careful when you're discussing these things because, of course, your enthusiasm can affect your judgment and, of course, obviously affects your presentation to the patient. So that was a lot of information to go through, but I think hopefully I've given you a window into a number of things to think about and in the future. And in summary, really, I think quality evidence summaries such as living guidelines are going to become essential for the dissemination of new knowledge for the practitioner. And we're already on the way to getting into that sphere. New technology, including machine learning and crowdsourcing, will be needed to get over the hump of all the volume of material that we've got to go through as far as evidence. We certainly need additional evidence into implementation science and to improve knowledge translation and incorporation of the evidence-based information that we have. And I think the last thing, which is important for surgeons specifically, we've got to take a leadership role in structured incorporation of new technology in your practice. I'd like to thank you for having me today. And really, it's been a pleasure getting to know both the residents and the staff a little bit better. And it's also been quite an honor to be invited as a Phil Gordon lecturer. Thank you. Oh. If I've got my words.
Does anyone have any questions for Dr. Buie after this excellent talk?
Oh, there's Leanne. I see you.
Yeah, hi. Sorry, great to see you, sort
to
of,
see you.
but hear your talk, and a really great talk and lots of food for thought. So thank you, Don, very much.
Thanks, Leanne.
Had a question, or just to get your opinion about it. At the Ideal Collaborative, was, as you probably know, but just for our audience here, especially our residents, trainees, was put together by Jonathan Meekins, who was a previous chair of our department when he was a Regis Professor of Surgery at Oxford. And part of the tension, I guess, the where that came from was the bias, I guess, that we have as surgeons that maybe randomized trials aren't really the way to evaluate, aren't the best way to evaluate all kinds of surgical interventions, but that was, I think, dispelled as a myth. But I think part of the tension for surgeons or people that like to try new things is that tension of wanting to be among, wherever that comes from. And you're right, I'm sure marketing and opinion leaders play a huge role. But that tension between not, wanting to innovate and move the field forward, as, lap chole and probably TATME are important, revolutions and evolutions in the practice. And some people see that right away and want to implement that, versus really being cautious, waiting for the trials to come out, all the stages, and then maybe you're kind of behind. And I think we can see that in some senses in colectomy, where even as a country, the United Kingdom then had to kind of, they waited for the NICE evaluation to come out, and then they were like, oh, it's okay to do, it's probably good to do, colon surgery, at least for cancer. And then, how are we going to train the country? And I think they did it really well. But how do you find the balance, I guess?
I think that's an excellent question. And it's one that I think is ongoing. I don't think we have the answer to that yet. And it may also depend on the innovation that we're talking about, man. And there's certain things where I think it does, if the consequences are very high, then we're probably going to have to be a little bit more cautious. In other words, with introduction. And it may be, I'm not sure if it'll be through societies or it's going to be through provincial bodies, but I think somebody will have to take the lead as far as trying to rein it in. I think what will help, one of the things that will help is if we have early and good turnover of evidence that's out there. I think that will also help. In other words, if there's CPG and guidelines that are coming out and being renewed, people will look at those, and it's been shown with the data from the Australian data that once they knew that the CPGs were being updated, on a weekly, as it turned out with COVID, or every 3 months with the stroke data, people read them and they used them. And I think that you could help along those lines with dissemination of information to people, saying that this has to be done in a controlled manner, or this is something that we can come widespread. I think the other aspect is the companies have to take on a little bit of ethical responsibility too. I think they have to be ready to help us get to where we want to get to, but they can't be pushing it, just for the reason of sales. So I hope that answers. I don't have the absolute answer, but I think that's where we're headed.
That's great. Thank you, Don. It's great to hear your thoughts. And
thanks, Leanne.
Thank you again for a great talk.
Is there any other?
Anyone have any other questions for Don?
There's one there.
Mm-hmm.
Go ahead.
How do we reconcile if a procedure that's done by someone is no longer recommended?
Say that again, sorry.
Here,
How do we reconcile if a procedure that's done by someone?
Hi, sorry, maybe I can I'll just ask you instead
Thanks,
of
Larry.
reading it up. That great talk, Don. It's always nice to hear these from you, especially someone who's kind of been part of the kind of guidelines committee in our societies for so long. So I guess when we talk about surgical innovations, new dissemination of new evidence, surgeons as a whole tend to be very, I guess, dogmatic, right? So, and we saw this with enhanced recovery, that it was quite clear relatively early on that the evidence was overwhelmingly in favor of something that was a complete paradigm shift from what people were doing for decades, right? And that's just kind of the perioperative management. How do we reconcile when someone has been doing a procedure for a very long time, and then all of a sudden there's this, whether it's new or kind of depending on what stage of the ideal thing is, no longer, let's just take laparoscopy for whatever procedure, and someone who's done it open for a very long time, and the evidence is clear that okay, like MIS, whether laparoscopy, robotics is better, whatever. How do we reconcile that? Like this person now has to completely change their practice, relearn something that may take years to really perfect. And then, these patients in the meantime may not have
Mhm.
the best outcome. You know what I mean? It's just,
I
it's
do.
always, it's like very hard.
Yeah.
It's like relatively easier in medicine where it's just like a medication change, quote unquote, which I don't mean this in a bad way, but like for a surgical technique, sometimes it takes
Mhm.
years and like tens of cases to practice to get better.
That's a great question. And I think we may have to make a paradigm shift in as new technology comes on board, because I have a feeling that not all of it's going to be simple on the uptake. If it's simple, there's an easy answer to your question. But if it's not, then it's a difficult answer. And it may be that the paradigm shift comes collectively from surgeons. We recognize this is technically difficult. And we recognize also that not everybody should be doing it. And that's a very hard, that's a hard conversation to have. We did have that to some extent in Alberta when we were doing the rectal cancer project. And in fact, we showed that the outcomes were worse in certain areas with certain people who didn't do a lot of it. And so we actually, in a tactful way, asked them to transfer those patients to other centers that did higher volumes. And in fact, when confronted with the evidence done in a proper way, a careful way, it was actually myself, I was really careful with them and in private. And I think none of us want to hurt people. I think that's one of the tenets of coming into medicine or surgery is you're trying to help people. So I think from an altruistic point of view, most of us will back down if we can't do it. If we find that it's going to be difficult to learn, I think most people will agree to have somebody else be doing that. So I think there is potential here, but it's going to take a different paradigm shift within organizations and hospitals to take that on. But I think it's necessary.
Okay, then we'll close the question time, and we thank Dr. Buie for all his hard work. We worked him really hard the past couple of days, and we have some gifts for you. So the first thing is a plaque thanking you for your great work, for being the fourth Phillip H. Gordon Visiting Professor.
Thank you very much, Caroline.
And then we have some souvenirs for you to remind you of the great time you spent with us at McGill.
Thank you. I must confess that it's been a real honor, and I've been just thrilled to be here and to see you guys again. One of the things which we talked about yesterday, it was just nice from a social point of view to see each other, and I think we all recognize the need for social interaction, even amongst our colleagues. It's just it's been too long. It really has been. So it's been great. Thank you again for inviting me.
Pleasure.
And thanks to all of you for attending today. I really appreciate it.